Hello, my name's Austin Worth, and welcome to the second past test lecture on infectious diseases, and I've entitled this lecture Clinical Presentations. In this lecture we'll cover a range of topics, including congenital infections, neonatal sepsis and meningitis, meningococcal disease, viral rashes and infections, and finally we'll end up discussing some of the other causes of fever. One of the difficulties with some of these topics, particularly congenital infections and viral exanthema, is that all the different diseases are actually very similar. So when you're working through these slides, try to concentrate on picking out the differences and hang the rest of the information on the differences between these various conditions. Let's start with a question. The following are true of toxoplasmosis. A. It is mostly transmitted through the respiratory route. B. It is a cause of convulsions in the neonatal period. C. If mother's infected in the first trimester, it seldom causes fetal abnormalities. D. If mother has Toxoplasma IgM antibodies, then she should have plasmapheresis. E. Undercooked meat is a common source. Okay, the true answers are B and E. Okay, congenital toxoplasmosis. It's a very difficult topic because it's not terribly common in this country, and until you've seen a case, it's always very difficult to try to remember facts about it. But it presents with a classical triad of chorioretinitis, which ophthalmologists tell us looks quite different to the CMV retinitis, hydrocephalus, and intracranial calcification. But remember that in 70 to 90% of babies, this condition is asymptomatic at birth. There are various other symptoms and signs these children get, including the usual things that you get with congenital infections: rashes, hepatosplenomegaly, lymphadenopathy, thrombocytopenia, and jaundice. But remember, these children also get microcephaly, or have microcephaly. They can have seizures, and they can also be deaf. And a lot of these things will be ringing out and reminding you also of congenital CMV. Long-term sequelae of toxoplasmosis include long-term seizures and epilepsy, deafness, blindness, and microcephaly. So what is toxoplasmosis? Well, it's caused by a protozoa called Toxoplasma gondii. Infection of an unborn baby, particularly if infection occurs during the first trimester, is more likely to lead to the congenital toxoplasmosis. Postnatally acquired infection is usually asymptomatic or a benign condition. But infection in immunocompromised patients, and we particularly see this in HIV and children post-bone marrow transplant, can lead to a more severe condition, often presenting with encephalitis, a space-occupying lesion in the brain, or pneumonitis. Transmission of the protozoa is via two main routes. Firstly, there is transmission via the oocytes in the stool, and this is generally from cat feces, and cats are the definitive source of toxoplasmosis. However, this organism also has a range of intermediate hosts, which include cattle, pigs, and sheep, and the cysts exist and survive in the meat of these animals, and therefore certain poorly cooked meats can also lead to transmission. So both are via the oral route. One is via the fecal oral route, the oocytes, but the other is through food. Diagnosis is tricky, but has been made easier with the wider availability of PCR-based techniques. PCR can be performed on the blood of the mother, the blood of a newborn baby, and also on the amniotic fluid. The old serological tests consisted of an IgM test, which had very poor sensitivity, only picking up about 80% of positive infections. A high affinity IgG, or IgG-HA, which suggested infection within the last 12 to 16 weeks, and a low affinity IgG, which only was evidence of previous infection. Overall, children of mothers who have a primary toxoplasmosis infection during pregnancy, there is a transmission rate of approximately 30%. Of these, 30% of children will be symptomatic. I'll just cross-reference you back to the statement I made at the beginning of this slide, that 70 to 90% of children with congenital toxoplasmosis are asymptomatic at birth. So, of those with infection, 30% are symptomatic, but only 70 to 90% of these children actually are symptomatic at birth. The remainder become symptomatic later on. Treatment of congenital toxoplasmosis is long and complicated. The first difficult decision is deciding who requires treatment. If an infant is symptomatic, and the mother has evidence of primary toxoplasmosis infection during pregnancy, then the infant needs treating. If the infant has an IgM or an IgA positive serological test, then as these cannot cross the placenta from the mother, then the infant is positive and requires treatment. If only the IgG is positive, then samples must be taken and the titers of IgG must be compared to the mother's titers. And if the titer is the IgG titer is rising in the infant on consecutive samples compared to the mother's titer, then the infant needs treating. For asymptomatic infants, the treatment is with spiromycin, and this is the same treatment for pregnant mothers if they are diagnosed during pregnancy. For symptomatic infants, then the treatment of choice is sulfadiazine and pyrimethamine with folinic acid rescue to try to prevent myelosuppression. This is the same treatment for immunosuppressed patients as well, and treatment for an infant is for a whole year. Finally, cotrimoxazole can be used for prophylaxis in immunosuppressed patients who've completed a treatment course, or those who are deemed to be at high risk of developing toxoplasmosis. So moving on to talk about congenital CMV. CMV is a human herpes virus, and I have discussed the human herpes virus infections in greater detail in the first infectious diseases lecture under basic science. Normally CMV causes a benign infection, an acute infection, usually fairly similar to EBV or glandular fever, but usually milder. However, its major burden as a pathogen is as a congenital infection. Approximately 0.5 to 1% of all infants born in the West are congenitally infected with CMV. Of these, approximately 10 to 20% are symptomatic. About half of those have an acute presentation, which is the presentation we think of with congenital CMV, with IUGR, microcephaly, jaundice, purpuric, hepatosplenomegaly, and then retinitis and intracranial calcification, and some or all of these. The remaining 5% of children who are symptomatic develop sensory neural deafness, but this is only detected later on. This is a major cause of deafness in the UK and accounts for approximately 200 new cases of deaf children each year. CMV infection to an infant can be antenatal via the placenta, or it can be perinatal via cervical secretions picked up during delivery or from the milk. Like all congenital infections, the earlier the infection is picked up, particularly if it's in the first trimester, the more likely the infection is to cause symptomatic disease. The later during a pregnancy that a primary CMV infection is encountered, the more likely the virus is transmitted, but the less likely it is to cause problems. CMV infection in mothers can either be primary infection, so the first time the mother has ever seen CMV, and she will get a viremia from that, or it can be reactivation of a secondary infection. It's important to remember that CMV, once you get CMV, it is never cleared from the body. So it remains latent in white blood cells for the rest of your life. Diagnosis of congenital CMV is difficult, and the gold standard is the proof of isolation of CMV within 3 weeks of birth. This is more straightforward in a child who's symptomatic, because the necessary samples can be taken at that time, and a diagnosis can be confirmed. However, in a child who subsequently develops deafness, it can be very difficult to go back and discover samples on which the testing can be done. This has been made easier with the advent of PCR, and we are now using PCR retrospectively on guttery spots to confirm a diagnosis later on. In addition to PCR, there were another number of serology tests which are being used less and less. Initially, there is the rapid antigen test, which can be detected on any body fluid, urine, blood in particular. This is detection of the CMV antigen, and therefore corresponds to the presence of virus in those being excreted in those body fluids. A supportive test is a high titer of IgM in the blood, but the use of these tests has now largely been superseded by the use of PCR. CMV can be treated. First-line treatment is with ganciclovir, and second-line treatments are with foscarnet or cidovovir. Unfortunately, all these drugs have very significant toxicities, both with myeloid suppression and causing renal impairment. The treatment of congenital CMV, or proven congenital infection, with these agents remains controversial at present. Okay, shall we take another question? A 16-year-old girl has positive syphilis serology identified after giving birth to a 3-kilo term baby from a concealed pregnancy. She has no visible genital lesions, but has a macular rash on her palms and soles. Her rapid plasma reagin, RPR, is positive, and the treponema pallidum particle agglutination, TPPA, is positive. The following are correct. A. The mother's result is most likely a false positive. B. Treatment with oral erythromycin during pregnancy is recommended to prevent congenital syphilis in the neonate. C. Clinical examination at birth will determine whether or not the baby has congenital syphilis. D. Nasal congestion is a common feature of congenital syphilis. E. The baby should be treated for congenital syphilis. Okay, and the answers are D and E are correct. The others are false. Although rare, the incidence of syphilis is increasing in the UK, and it is likely that we will begin to see more and more congenital syphilis. Syphilis is caused by the spirochete, Treponema pallidum. Diagnosis of syphilis remains tricky. Gold standard is identification of the organisms on dark field microscopy, This is usually performed on as a smear of mucosal fluid, either from the genital tract or from other sources. Blood tests are confusing, but you should think of them as being split into non-treponeal tests, which are labelled as above. Now, these are antibodies to antigens contained within the spirochete. They are cheap tests, they are rapid to get results back, but they can be non-specific, and there are also relatively high rates of false negatives with this. So the three non-treponeal tests named up here, these are just three examples. This is the RPIR, which is the Rapid Plasma Reagin Test, the VDRL, the Venereal Disease Research Laboratory Slide Test, and the ART, the Automated Reagin Test. False negatives are particularly common early in primary infection and in late congenital infection. And false positive results, so cross-reactivity of these tests, can be seen in a number of other conditions. The important ones to remember are Epstein-Barr virus infection, TB, SLE, hepatitis, varicella-zoster infection, measles, and lymphoma. Treponeal tests, or the TPPA, treponeum pallidum particle agglutination test, directly tests the antigen itself and is therefore more specific. However, it's important to remember that even this test has false positives with Lyme's disease and with yours. We don't have enough time in this lecture to talk fully about congenital syphilis, as it is a huge topic. However, I hope to give you just a very, very quick overview in this slide. Transmission generally occurs late in pregnancy and is most usually caused by inadequately treated primary or secondary syphilis. Two clinical syndromes are generally recognised: the early congenital syphilis presenting within the first 3 months. These children are very frequently snuffly and can have hepatosplenomegaly and lymphadenopathy. They also frequently have rashes that can be highly varied but frequently desquamate. These children have difficulty thriving, can have neurological phenomena, and classically get an osteochondritis. So investigation of this includes long bone x-rays, but also a CSF examination should be considered to check for neurological involvement. Late congenital syphilis usually appears after 2 years of age and can involve the central nervous system, bones and joints, teeth, eyes and skin. The skin is an interstitial keratitis. Classically, these children get an 8th nerve deafness and Hutchinson's teeth, which are peg-shaped, notched central incisors. This triad is called Hutchinson's triad. Treatment of choice for both congenital syphilis and syphilis during pregnancy is penicillin with a 10-day course. However, it is important to monitor the child afterwards because treatment failures do occur. Moving on from syphilis, there are several other congenital infections to consider. This list is not exhaustive, but just contains some other conditions that it's worth thinking about. Congenital rubella is very rare now in the UK. The classical clinical presentation is very widespread, but includes cardiac defects, that's septal defects and pulmonary stenosis typically, persistent ductus arteriosus. These children classically get petechiae and other rashes. They have neurological involvement with seizures, developmental delay, sensory neural deafness, and their eyes, they have cataracts, they develop cataracts and have microphthalmia. Varicella infection during pregnancy results in an approximately 2% incidence of congenital varicella with a primary infection. This is more likely if the primary infection occurs in the first trimester. Clinically, these children have quite a severe chorioretinitis and microcephaly. They also get limb deformities and quite a characteristic scarring of the skin. Typically, these are asymmetrical. Primary parvovirus infection in pregnancy characteristically causes miscarriage or can result in fetal hydrops. The reason for this is parvovirus is very myelosuppressive and particularly suppresses red blood cell production. This then results in a very anemic baby. With herpes simplex virus, there is an approximately 5% risk if the mother has active disease during birth, but this rises to a 50% risk if this is a primary infection. Neonatal and childhood HSV infections are discussed more fully in Lecture 1. Gonococcal and chlamydial infections typically present with a conjunctivitis, and it is important to consider these in any newborn baby presenting with exudative eyes or a conjunctivitis. Treatment for gonococcus is a single dose of ceftriaxone, and for chlamydia, erythromycin or a macrolide antibiotic is the choice. Right, we'll move on from congenital infection and start with a question. So question 3. Group B streptococcal infection in neonates. A. Can be reduced by universal screening in pregnancy and intrapartum prophylaxis. B. Occurs at least 25 per 1,000 live births. C. Is rarely indicated in cases of proven meningitis. D. Yields positive blood cultures in nearly all cases. E. Presents in the first 7 days after birth in over 95% of cases. And the answer is that only A is true. So neonatal sepsis is one of the answers for the purposes of the exams that you should always consider. Sepsis is divided into the 2 clinical syndromes, early onset and late onset. The common pathogens for early onset are Group B strep, which is the most common, then E. coli and Listeria. By definition, this is infection within the first 7 days of life, and the etiology is thought that these infections are derived from birth canal flora. Late onset infection, by definition infection between 7 days and 3 months, is usually caused by nosocomial infection, i.e. hospital-acquired, or due to a specific focus. This focus can be lines in situ, either central or peripheral lines, and for that reason, if you count all data, the most common pathogen is Staphylococcus epidermidis. However, other foci should be considered as well, including the renal tract, meningitis, and osteomyelitis. Group B streptococcus, otherwise known as Streptococcus agalactiae or beta hemolytic strep, is the most important neonatal pathogen. 25% of UK mothers are carriers, and there is an ongoing debate as to what the best way of addressing this situation, either through universal screening, which is more common in the United States, or a risk factor based approach, which is what's generally done in the UK. It is important to know your risk factors for Group B streptococcus infection, which include all the usual risk factors for assessing a child for neonatal sepsis. So a raised or low white blood cell count, temperature or glucose instability, a floppy baby with poor activity, acidosis on a blood gas, jaundice, hepatosplenomegaly. These are just some of the risk factors. Late infection usually presents with a more indolent clinical course, so often with fever and then evolving meningitis, sometimes presenting with increasing floppiness or just failure to feed. The average time of presentation is between 3 to 4 weeks. Of Group B streptococcal infection, about 1/3 is of late onset, and of those, 90% are made up of meningitis. However, there are several other foci that should be considered, particularly if the CSF is clear, and these include a cellulitis, a septic arthritis or an osteomyelitis, and a lymphadenitis. The overall incidence of neonatal Group B strep infection is not as high as 25 per thousand, but runs between 1 and 4 per 1,000 live births, although this is highly variable and is more common in certain ethnic groups. In the US, this is classically Hispanics and American Indian populations. Group B strep, although devastating infection in neonates, does not usually cause significant infections later in life, and is actually a very sensitive organism. Most are sensitive to penicillin, and gentamicin just adds synergy. Another important pathogen to consider in neonatal infection is Listeria monocytogenes. Listeria is caught by mothers by drinking unpasteurized milk or uncooked meats, and deli-related food and pate are important focuses of infection. Mothers typically have a mild flu-like prodromal illness, and neonatal infection typically causes prematurity and staining of the liquor and foul-smelling liquor. It is important, if possible, to examine the placenta, which is often very, very abnormal and infected, and can be sent for culture. Also, the babies have a characteristic erythematous rash, although this often presents after the baby has initially presented, and therefore is not always helpful for diagnosis. Biopsy of this rash shows granulomas. Although 90% of Listeria is sensitive to penicillin, 100% is sensitive to ampicillin. So this is why it's very important to add in ampicillin if Listeria is considered. In any sick neonate, it is essential to rule out neonatal meningitis. The contraindications for lumbar puncture in a neonate are quite different from those for an older child due to the open fontanelle, making it a much less risky procedure. However, there are 3 contraindications which are stated in this slide. Non-communicating hydrocephalus, a baby who's clinically too unstable to tolerate the procedure, or bleeding problems, a thrombocytopenia or coagulopathy. Treatment of meningitis is stated as below there. If an organism is grown, then the antibiotic therapy can be rationalised once the baby is stable. Question 4. Meningococcal septicemic shock A is most frequently caused by Group A Neisseria meningitidis. B is a contraindication to lumbar puncture in a child with meningism. C is the only cause of fever with a purpuric rash. D has a better prognosis than meningococcal meningitis. E. Close contacts should be given prophylaxis with doxycycline. And the answer is that only B is true. Meningococcal disease is most commonly caused by Group B Neisseria meningitidis. The other subtypes that commonly or more rarely cause disease are C, A, Y, and W135. There is no vaccination against Group B meningococcus, There is the conjugate vaccine against meningococcal C, which is part of the routine vaccination schedule. And there is a quadrivalent polysaccharide vaccine against subtypes A, C, W and Y. This is a good time to emphasise the importance of knowing the difference between a conjugate and a polysaccharide vaccine. I don't have time to discuss this here, but you should make sure that you understand that. Meningococcal disease, 15% of cases present with pure meningitis, 25% with pure septicemia, and 60% with a mixed picture. Maybe counterintuitively, those patients presenting with meningitis have a better prognosis than those with sepsis. And this is because the infection is picked up at an earlier stage because the child develops more symptoms sooner. The key for management of meningococcal disease is aggressive fluid management. And I'm sure you all know from your APLS courses that standard treatment is eubolus with saline or albumin up to 60 ml per kilo, and then the child requires intubation to allow further fluid to be given. Mortality remains very high, with a sepsis mortality of approximately 10%. This is lower in meningitis, and actually, provided you get over the disease, is usually free of sequelae, with less than 10% developing deafness. The bug, the meningococcus, is usually highly sensitive to antibiotics, and penicillin is usually sufficient. 5 days are enough for uncomplicated sepsis, and 10 days treatment are sufficient for meningitis. Defects within the late components of the complement cascade, that is C6, 7, 8 and C9, are associated with a specific susceptibility to meningococcal disease. In the UK, this is particularly associated with the susceptibility to Y and W135 types. Diagnosis of meningococcal disease is primarily on blood culture, but can also be done on PCR. It is important to know the guidelines for prophylaxis for contacts of patients with meningococcal disease. These prophylaxis is appropriate for same household contacts and for anyone who has been within kissing contact. Standard prophylaxis is 4 doses of rifampicin. However, it's important to warn patients who take these of the side effects of rifampicin. It can stain contact lenses and urine red. It should not be given to any patient with liver disease. It interacts with the combined oral contraceptive pill and should not be used in pregnancy. Alternatives include either a single dose of ciprofloxacin or a single dose of ceftriaxone, which can be given intravenously or intramuscularly. Viral meningitis or encephalitis can present very similarly, but usually is a much less severe disease with less systemic response. There is a wide range of pathogens that can cause these syndromes. The most common viruses causing meningitis are listed here. It's important to remember that enterovirus is a very large family of viruses containing several that you will have heard of. So the 3 most common that cause viral meningitis are Coxsackie A, Coxsackie B, and echovirus. But this group also contains the poliovirus. Encephalitises are more severe infections and are classically associated with findings on imaging, so MRI or CT scan, in the parenchyma of the brain. The most frequent and most common is herpes simplex virus, which is associated with changes in the temporal lobes. And again, this is discussed in Lecture 1. The other herpes viruses can also cause this, and there is the very, very rare encephalitis associated with MMR vaccination. Right, let's take some more questions. Question 5. A 5-year-old child has had a fever for 3 days, followed by a maculopapular rash and a severe cough. Which of the following is the likely diagnosis? Roseola infantum, rubella, measles, chickenpox, or glandular fever? And the answer is measles. And the clue in this question is the severe cough. Question 6. A 6-month-old boy is brought to accident and emergency by his parents because of a fever for 3 days. He has been slightly irritable and has been feeding less than usual. His temperature measured at home has been up to 40 degrees. He looks quite well, but his temperature remains raised and no focus can be found. The only finding of note is a few suboccipital and posterior auricular lymph nodes. He is admitted to the ward overnight for observation and his temperature subsides. On the morning rash, he is found to have an erythematous macular rash on his trunk. Is this A. measles, B. parvovirus B19, C. rubella, D. human herpes virus 8, or E. human herpes virus 6? And the answer is E. HHV6. Again, the clue here is the very high temperature while remaining reasonably well. Measles is an important topic that you should know well. It is caused by the RNA virus paramyxovirus and is spread by droplet infection with an incubation period of 8 to 12 days, and children remain infectious for 3 to 5 days following the appearance of the rash. Clinically, these children are characteristically really miserable and unwell. They have a good going fever and usually have respiratory symptoms as well, which can just be sneezing or coryza, but can be a cough and lower respiratory tract signs. They classically have a conjunctivitis, as shown in this picture, and the characteristic cough-lick spots, which are not usually found, often appear a couple of days later. They're shown, these white plaques are shown in this photo here. Complications from measles are relatively common. The most common one is otitis media, followed by a lower respiratory tract infection. Encephalitis is relatively common with an incidence of 1 in 1,000, as is idiopathic thrombocytopenia purpura. The subacute sclerosing panencephalopathy with a much, much worse prognosis is much rarer. Corneal ulceration associated with measles is a real problem in the developing world, and this is associated by a vitamin A deficiency that measles can induce. This has been much improved with widespread vitamin A supplementation programs run by the WHO. Diagnosis of measles is made by IgM-specific antibodies in the saliva. Mumps is also caused by an RNA paramyxovirus. The incubation period, however, is longer, at 12 to 25 days. And the characteristic finding with mumps is parotid gland swelling or edema. This is usually bilateral in about 80% and can cause pain on chewing, which is often appears before the parotid enlargement is clinically visible. The other glands that are involved are the testes However, the orchitis is usually unilateral. The most common complications are meningitis and pancreatitis. The meningitis is associated with a very good prognosis, and of children with mumps, over 50% have a leukocytosis, or a raised white cell count, on the CSF. Other complications from mumps include arthritis, thyroiditis, mastitis, glomerulonephritis, and ataxia caused by a transverse myelitis. Children do much better than adults in this condition, and in pregnancy, if a primary infection is encountered, then there is an increased risk of abortion. Rubella is the mildest clinical infection of the three contained protected with the MMR. Unlike the other two, it is caused by an RNA toga virus. Its incubation period is very similar to mumps, and the rash that children get with rubella is much less florid than that seen in measles. They do also get a conjunctivitis, and they can also get an arthritis and an ITP-like syndrome, which is frequently the most troublesome complication. Encephalitis is not as common as it is with either mumps or measles, but still occurs. The big problem with rubella is congenital rubella, of which the greatest risk of getting it is having a primary infection in the first trimester. And we have already discussed congenital rubella earlier. Slap cheek syndrome is caused by parvovirus B19 infection. This is a DNA virus, and just to let you know, there is only one type of the parvovirus, and the fact that it's numbered B19 is just confusing. This clinical condition is also called erythema infectiosum. Parvoviral infection has an incubation period of 13 to 18 days. The child usually has a mild fever and malaise, but very, very prominent rash. It's just worth thinking about that when comparing it to roseola infantum, which is the other way round. The rash can come and go, but usually it is a benign condition. Not if it's caught by children with underlying problems with red blood cell synthesis, and the classic condition which this causes problems with is sickle cell anemia. We have talked a little bit about congenital parvovirus B19 causing neonatal hydrops and thrombocytopenia. There's a 50% transmission rate during primary infection of mothers, and this infection can be monitored if there's a possibility of the mother having had parvovirus by measuring serial IgM measurements in the mother. If this is suggestive of infection, then the baby needs regular scanning to assess the possible development of hydrops. And if this is the case, intrauterine transfusion can be performed. So roseola infantum is caused by human herpes virus 6 or 7. We've already talked in Lecture 1 extensively about herpes viruses, but to remind you, they're double-stranded DNA viruses. And in this condition, there is a very high fever, invariably over 40 degrees, that lasts for 3 to 7 days. But the child is actually very, very well. This is associated with a relatively high risk of febrile convulsions. And a number of years ago now, it was proposed that HHV6 may be responsible for many of the cases of encephalitis and meningitis that we see. Subsequent studies have suggested that, although it is an important pathogen in these children, it's certainly not responsible for the majority of those cases. Again, characteristically with this disease, there's minimal focal pathology. There are a number of other diseases and infections that must be considered for the child with the rash and the high fever. Perhaps the most important one is scarlet fever, or group A streptococcus, or alpha hemolytic strep. Classically, this presents with a tonsillitis, and it's important to consider the sequelae, which can include glomerulonephritis, and very rarely these days rheumatic fever. Glandular fever, enterovirus infection, Kawasaki's disease, and early meningococcal should all be considered in a child with a blanching rash and high fever. And finally, acute lymphoblastic leukemia frequently presents with this sort of presentation as well. Question 7. Kawasaki's disease in the first week of illness can cause A. coronary aneurysms, B. unilateral cervical lymphadenopathy, C. strawberry tongue, D. peeling hands, E. raised DSR. And the answer is that B, C and E are all true. Peeling hands, D, usually starts from about 10 days of the illness, whereas coronary artery aneurysms develop later, but both are associated with Kawasaki's disease. Strawberry tongue, the classical condition to consider with that is scarlet fever, which is a streptococcal infection. So Kawasaki's disease, or its other name, mucocutaneous lymph node syndrome, has 7 diagnostic features. To make a classical diagnosis, a child should have fever for 5 days, and 4 out of the 5 conditions found within the red box. However, Kawasaki's disease also has several other clinical features. Children are miserable. They frequently have, if they have been vaccinated with BCG, the BCG scar is frequently swollen and can become purulent. They have sterile pyuria and can have arthritis, and occasionally develop a pericardial effusion. The peak age of incidence is 2 years of age, and children who develop Kawasaki's disease less than 1 year of age or greater than 8 years of age are described as having atypical Kawasaki's disease. In addition to this, many children will have incomplete Kawasaki's disease, where they don't have the full house of symptoms and therefore don't formally fit the diagnostic criteria, but nonetheless seem to have the same Kawasaki's disease process going on. Thrombocytosis, which is a reflection of an ongoing inflammatory process, usually starts in week 2 to 3, and therefore, although helpful in diagnosis, it's important to consider the disease before the platelet count starts going up. Treatment. Kawasaki's disease is a vasculitis, and therefore has to be treated with immunomodulation. First-line treatment, as soon as the condition has been considered, is intravenous immunoglobulin at 2 grams per kilo, so that's high dose, and this has been found to be beneficial if it is given within 10 days. Although it is worth bearing in mind, 10 days was an arbitrary cut-off used in the initial treatment trial for Kawasaki's disease. Aspirin should also be started at high dose, and this should be continued until the temperature settles. Low-dose aspirin should then be continued until 8 weeks of age. These children should also have an echocardiogram that should be repeated regularly, and 2 to 4% of children will develop coronary artery aneurysms even with intravenous immunoglobulin, whereas without, this figure rises to 20 to 25%. The problematic aneurysms are the so-called giant aneurysms, which are greater than 8 millimeters in diameter. And in severe cases, these can need intervention, such as stenting or in the worst case scenario, a cardiac transplant. The investigation and the diagnosis of a pyrexia of unknown origin, once basic investigations have been performed, is complicated and involved, and is usually the preserve of a paediatric infectious diseases subspecialist. However, it is important to know the range of some of the clinical syndromes that can give rise to this, so that a good general investigation can be initiated. This slide gives an overview of the main areas which are included within fever syndromes. We've already talked about viral infections, and for ongoing fever, the herpes viruses and the hepatitis viruses are the most important. Unusual bacterial infections, often from unusual sources or focuses, are also important to consider. These include TB, typhoid, Bartonella, brucellosis, Borrelia, and Q syndrome. And therefore, with these conditions, it's important to take a thorough travel history, a thorough contact history, and a good history of contact with any animals. Malignancy should always be looked for extremely hard in these children, and rheumatological conditions become more likely as the infective causes are ruled out. There are a number of immunological conditions that should be considered, particularly relating to recurrent infection, and perhaps the most important ones that might be missed are HIV, chronic variable immunodeficiency, and cyclical neutropenia. And finally, there are the periodic fevers, three of which I've mentioned here: familial Mediterranean fever, hyper-IgD syndrome, and TRAPS syndrome, which is the TNF receptor associated periodic fever syndrome. Final question. Tonsillar exudate is seen in which of the following conditions? A. Diphtheria, B. Epstein-Barr virus, C. AIDS, D. Kawasaki's disease, and E. Streptococcal infection. The answer is that D is false, but all the rest are true. Kawasaki's disease classically presents with non-purulent symptoms, so the conjunctivitis is non-purulent, and the mucositis and the tonsillitis will be non-purulent. So tonsillitis is a very common clinical presentation in paediatrics and does seem to come up fairly regularly in multiple choice questions. The majority of tonsillitis are viral and therefore do not require antibiotics. Of bacterial infections, almost all will be group A Streptococcus, which can be treated with penicillin V, with guidelines varying between a 7-day course and longer. Remember the long-term sequelae, which are very rare in the UK, of rheumatic fever, glomerulonephritis, and neurological complications such as Sydenham's chorea. Diphtheria is very, very rare, although there has been a case in the UK this year, that's 2009. This presents classically with a grey, thick membrane over the tonsils and a bull neck, so a widened neck that's associated with airway obstruction. This is a very serious condition that's toxin-mediated and results in a myocarditis as well and a peripheral neuropathy. Epstein-Barr virus is a common cause of tonsillitis and also classically causes a membrane over the tonsils. Epstein-Barr virus can result in developing a more severe rash upon starting amoxicillin, and that's why the advice for primary treatment of tonsillitis, which is felt to be bacterial, is penicillin V and not ampicillin or amoxicillin. The greatest danger with Epstein-Barr virus is airway obstruction, and this should be treated with hydrocortisone to damp down the inflammation. Just remember, Epstein-Barr virus can be really quite a protracted, prolonged illness as well. So to conclude, I hope there are a number of key elements that you're able to take away from this talk. Although there's been a lot of information in here and there's always a lot to take on board, I hope following this you'll have a good idea about how you'd go about investigating congenital infection, have a good overview of the microbiology and treatment of neonatal infections, have a better idea of discriminating between the viral exanthema and perhaps, in the context of the exam, more importantly, get the question right and know what to look out for in the clues in the question as to which virus they're driving at. Recognition and treatment of Kawasaki's disease, and have a good idea of differential diagnoses lists for prolonged fever, rash and meningoencephalitis, so that if you are stuck in the exam, you have a logical framework to work through other possible diagnoses. And good luck with the exam.